This module is about musculoskeletal disorders, particularly impairment of the back and spine. They are one of the leading health problems, and they are the #1 cause of disability. The functional and psychological limitations for the patient may be severe. Anytime you have a musculoskeletal disorder, it affects every other system, just like other major diseases do. Nurses provide care in both inpatient and outpatient settings. Because of this, nurses should be cognizant of these limitations and the effects these disorders may have on these patients. The economic costs in terms of loss of productivity, medical expenses, and other costs are among the highest for any medical diagnosis. Here are the learning objectives for this chapter. Please take a moment to review each one of these. You can speak to these and apply these to your learning practice. Then you've accomplished your learning for this chapter. Osteoarthritis, or OA, which is probably how I'm going to call it the rest of this slide, is the most common form of arthritis. Some people call it degenerative joint disease or wear and tear arthritis. It occurs most frequently in the hands, hips, and knees. With osteoarthritis, the cartilage within a joint begins to break down and the underlying bone begins to change. These changes usually develop slowly and get worse over time. OA can cause pain, stiffness, and swelling. And I just want to mention here that we're going to cover a couple of types of arthritis. I would make a table and know the differences between them so that when you get test questions, you can go, oh, that one's this and this one's that. So know that osteoarthritis can cause pain, stiffness, and swelling. In some cases, it also causes reduced function and disability. Some people are no longer able to do daily tasks or work. Signs and symptoms are pain, aching, stiffness, decreased range of motion or flexibility, and swelling. Risk factors are joint injury or overuse. With injury or overuse, such as knee bending and repetitive stress on a joint, it can damage a joint and increase the risk of OA in that joint. So think about if you work at a job and you type all day, not only can you get, what is it called? Carpal tunnel syndrome, which is the nerves are impinged, but you also can have the repetitive stress of that can cause osteoarthritis. Age is one of the risk factors for developing osteoarthritis. It increases with age. Gender, women are more likely to develop it than men, especially after age 50. Obesity, extra weight puts more stress on the joints, especially weight-bearing joints like the hips and the knees. This increases the risk of OA in that joint. It can also have a metabolic effect that increases the risk of OA when you have obesity. Genetics, people who have family members with OA are more likely to develop it. People who have hand arthritis are more likely to develop knee arthritis. There is no cure for osteoarthritis. The treatments are increased physical activity, which they're not going to want to do, but they will feel better once they get moving. Physical therapy with muscle strengthening exercises, weight loss, medications including over-the-counter pain relievers and prescription medications, supportive devices such as crutches or canes, and surgery if other treatment options have not been effective. Our nursing interventions and considerations include a functional evaluation, focusing on the patient's ability to perform their ADLs, and also what is their balance like. Techniques of inspection and palpation are used to evaluate the patient's posture, gait, bone integrity, joint function, and the muscle strength and size. Specific assessments that the nurse should make regarding the pain include the following. Is the body in proper alignment when they're standing up? Are the joints symmetrical, or are there bony deformities present? So look at the picture of those hands above. See how they're obviously not looking like a normal, healthy person's hands. Is there any inflammation or arthritis, swelling, warmth, tenderness, or redness? The patient's pain and discomfort must be managed successfully. Not only is pain exhausting, but if it's prolonged, it can force the patient to become increasingly withdrawn and dependent on others as the musculoskeletal disorder continues. Assessment of lifestyle changes. So function or mobility. Are they using aids to get through their day? And if not, do we need to provide them with some? And the pain management. If they're on a weight loss program, how's that going? They need to exercise based on their abilities and especially focus on strengthening muscle. Patient teaching. OA, pain may progressively worsen throughout the day. Teach your patients to plan activities in the morning when they may feel the best and in smaller increments of time throughout the day. Pain medication, when to take it and how much to take, any side effects or adverse effects. Take a look at the table in your MedSurg book in the chapter. I think it's table 1. It discusses age-related changes in the musculoskeletal system. Osteoarthritis or joint degradation can be part of these changes. Okay, what is osteoporosis? It's the most prevalent bone disease in the world. 1.5 million fractures occur every year because of this. Some of them require hospitalization, and that number has risen significantly over the past 2 decades. I will say this, osteoporosis can result in spontaneous fractures. So sometimes you'll have someone say they fell and broke their hip, but you don't know which came first. The hip fracture caused them to fall, or did they fall and break their hip when they have osteoporosis? The prevalence of osteoporosis in women older than 80 is 50%. The average 75-year-old woman has lost 25% of her cortical bone and 40% of her trabecular bone. Most residents of long-term care facilities have a low BMD and are at risk for bone fracture. 1/3 of all hip fractures occur among men, and men have a higher mortality rate than women after sustaining a hip fracture. Older adults absorb dietary calcium less efficiently and excrete it more readily through their kidneys. Postmenopausal women and older adults need to consume approximately 1,200 milligrams of calcium daily. Quantities larger than this may place patients at heightened risk of renal calculi, which is like a kidney stone, or cardiovascular disease. Osteoporosis is characterized by reduced bone mass, deterioration of bone matrix, and diminished bone architectural strength. The bones become progressively porous, brittle, and fragile. They fracture easily under stress that would not normally break bone. This occurs most commonly as compression fractures of the thoracic and lumbar spine, hip fractures, and fractures of the wrist. These fractures may be the first clinical manifestation of osteoporosis. So it's important to get the screenings done to check bone density. I believe they start checking for that in women over 50. Well, people over 50, but mostly women. The gradual collapse of a vertebrae may be asymptomatic. With the development of kyphosis, if you don't know what that is, look it up. There is an associated loss of height. The postural changes result in relaxation of the abdominal muscles and a protruding abdomen. The deformity may also produce pulmonary insufficiency and increase the risk for falls related to balance issues. So as you shrink and hunch over, you don't have room for your diaphragm to expand, and your lungs kind of get compressed in there too, so that's why you have that issue with pulmonary insufficiency. Age-related loss begins soon after the peak bone mass is achieved, which is somewhere in the 40s. Calcitonin, which inhibits bone reabsorption and promotes bone formation, is decreased. Estrogen, which inhibits bone breakdown, also decreases with aging. On the other hand, parathyroid hormone, or PTH, increases with aging, thus increasing bone turnover and reabsorption. This consequence of these changes is net loss of bone mass over time. So your risk factors for this osteoporosis disease are alcohol intake of 3 or more drinks daily, current use of tobacco products, family history, history of bone fracture during adulthood, inactive or sedentary lifestyle, inadequate calcium and vitamin D intake, low body mass index, so someone who's really thin, malabsorption disorders, such as eating disorders, celiac disease, or bariatric surgery, which can cause you to have the inability to absorb nutrients because food passes too quickly through the system. Men older than 60 years of age, women who are postmenopausal, someone who's taking corticosteroids like prednisone for longer than 3 months. Medical management of osteoporosis is a diet rich in calcium and vitamin D throughout life, with an increased calcium intake during adolescence and the middle years. This protects against skeletal demineralization. And regular weight-bearing exercise promotes bone formation, so it helps with bone modeling and strengthening. Recommendations include 20 to 30 minutes of aerobic bone stressing exercises daily. Osteoporotic compression fractures of the vertebrae are managed conservatively. Patients with these findings should be referred to an osteoporosis specialist. Most patients who experience these fractures are asymptomatic and do not require acute care management. So your nursing considerations for patients with osteoporosis, you want to educate them on factors influencing the development of osteoporosis, interventions to arrest or slow the process, and measures to relieve symptoms. The nurse should emphasize that people of any age need sufficient calcium, vitamin D, and weight-bearing exercise to slow the progression of osteoporosis. Patient education related to medication therapy like Fosamax. Fosamax is one of the medications that we use to treat this disease. And I believe we talked about it in a previous PowerPoint. Patients have to understand that having one fracture increases the probability of sustaining another. Relief of back pain resulting from compression fracture may be accomplished by short periods of resting in bed in a supine or side-lying position. The mattress should be supportive. Knee flexion increases comfort by relaxing back muscles. Intermittent local heat and back rubs promote muscle relaxation. The nurse should instruct the patient to move their trunk as a unit and to avoid twisting. When the patient is assisted out of bed, a lumbar or a lumbosacral corset may be worn for temporary support and immobilization, although it is frequently uncomfortable and it's poorly tolerated by many older adults. I would just say, really, you want to log roll your patient. You want the arms, legs, and trunk to move at the same time so you're not twisting. Constipation is a problem related to immobility and medications. Early institution of a high-fiber diet, increased fluids, and the use of prescribed stool softeners help prevent or minimize constipation. So look at chart 5 in your med-surg textbook for strategies to prevent osteoporosis. This slide shows progressive osteoporotic bone loss and compression fractures. This slide shows the typical loss of height associated with osteoporosis and aging. So this is kyphosis. You might have heard it referred to as a dowager's hump. Next condition is osteomyelitis, and that is osteo is bone, my is muscle, and litis is infection. So it's an infection of the bone that results in inflammation, necrosis, and formation of new bone. Patients who are at high risk for osteomyelitis include older adults and those who are poorly nourished or obese. Other patients at risk include those with impaired immune systems, those with chronic illnesses like diabetes, rheumatoid arthritis, those receiving long-term corticosteroid therapy or immunosuppressive agents, and those who use IV drugs. The initial response to infection is inflammation, which we know, increased vascularity, and edema. After 2 or 3 days, thrombosis of the local blood vessels occurs, resulting in ischemia with bone necrosis. So, ischemia. What does that mean? It's not getting good blood flow. And so, therefore, the brain or the bone starts to die where the infection is. And these are your signs and symptoms. This is what they look like. When the infection is bloodborne, the onset is usually sudden, occurring often with the clinical signs and symptoms of sepsis, such as chills, high fever, rapid pulse, general malaise. The systemic symptoms at first may overshadow the local signs. As the infection extends through the cortex of the bone, it involves the periosteum and the soft tissues. The infected area becomes painful, swollen, and extremely tender. The patient may describe a constant pulsating pain that intensifies with movement as a result of the pressure of the collecting purulent material. The surface area that lies over the infected bone is swollen, warm, painful, and tender to the touch. I mean, I'm showing pictures up here. You can look and see what it looks like. The patient with chronic osteomyelitis presents with a non-healing ulcer that overlies the infected bone with a connecting sinus that will intermittently and spontaneously drain purulent drainage. So look at this heel up here. Actually, it's on the next slide. Diabetic osteomyelitis can occur without any external wounds. microvascular and macrovascular pathophysiologic changes, along with an impaired immune response by patients with diabetes who have poor glycemic control, can exacerbate the spread of infection. The initial goal of therapy is to control and halt the infective process. General supportive measures such as hydration, a diet high in vitamins and protein, correction of anemia are instituted. The area affected with osteomyelitis is immobilized to decrease discomfort and to prevent pathologic fracture of the weakened bone. Bone infections are more difficult to eradicate than soft tissue infections because bone is mostly avascular and is less accessible to the body's natural immune response. Because there is decreased penetration by medications, antibiotic therapy is longer term than other infections. Typically, it's from 3 to 6 weeks, sometimes longer. However, if the therapy does not work, surgical methods have to be employed. And so we have surgical debridement to remove necrotic tissue. However, if x-rays or bone scans indicate osteomyelitis in the affected bone, excision of the necrotic bone must be done to promote healing. This leads to partial or complete amputations depending on how much of the bone has been affected. So our nursing interventions and considerations include taking care of the pain, assessing the patient for risk factors like older age, diabetes, long-term steroid use, a history of previous injury, infection, or orthopedic surgery. The gait may be altered as the patient avoids pressure in the movement of the area. In acute hematogenous osteomyelitis, the patient exhibits generalized weakness due to the systemic reaction of the infection. Physical examination reveals an inflamed, markedly edematous, warm area that is tender. Purulent drainage may be noted. The patient has an elevated temperature. With chronic osteomyelitis, the temperature elevation may be minimal, occurring in the afternoon or evening. The affected part may be immobilized with a splint to decrease pain and muscle spasm. The nurse monitors the skin and neurovascular status of the affected extremity. The wounds are frequently very painful and they must be handled with great care and gentleness. Elevation can reduce swelling and the associated discomfort that comes along with that. Pain is controlled with prescribed analgesic agents and other pain-reducing techniques. Treatment regimens restrict weight-bearing activity. The bone is weakened by the ineffective process and must be protected by avoidance of stress on the bone. The patient must understand the rationale for the activity restrictions, so make sure they do. The joints above and below the affected part should be gently moved through their range of motion. So you're doing range of motion exercises with them on that affected limb. So assisted range of motion more than likely, but it might be passive range of motion. The nurse encourages full participation in ADLs within the prescribed physical limitations to promote general well-being. So we want them, as always, to do as much as they can for themselves. We're monitoring for antibiotic effectiveness and superinfections like C. diff from long-term use of antibiotics. So how do we monitor for antibiotic effectiveness? Ask yourself that question, what are we looking for? What do the signs and symptoms look like for improvements, and what are we looking for in labs? The patient and family are educated about the importance of strictly adhering to the therapeutic regimen for antibiotics. Obviously, we want them to finish their antibiotics even when they feel like they have no more signs and symptoms, when to call the doctor, that kind of thing. They often need to learn to maintain and manage IV access because these are IV administration, and because it's long-term, they don't stay in the hospital for that typically. They may go to a SNF or long-term care, but a lot of times they're home. So these patients may have home health, or maybe we just teach them in the hospital and they go home and do it. So they really need to understand how to manage that IV access. We're teaching them about the medication, the dose, the frequency, the administration rate, how to safely store whatever med it is, and how to handle it safely, any adverse reactions, and obviously you would call the doctor if you have those, and whatever laboratory monitoring is requested by the physician. The nurse provides instruction on aseptic dressing changes. Because it's going to be a long-term IV antibiotic therapy, these patients are discharged to acute rehab, which I said, home, with home health, probably they're getting home with home health, but we still want to start teaching them in the acute care setting. They may come to an outpatient infusion clinic every day for their infusions if they're unable to manage it at home. This slide shows clinical manifestations of osteomyelitis. This is what I was referring to earlier about seeing the picture. You couldn't see the picture. Negative pressure wound therapy is a method of drawing out fluid and infection from a wound to help it heal. So a special dressing or bandage is sealed over the wound and a gentle vacuum pump is attached. Kind of think of it like your SCD is how I said it, massages. It kind of does that. It promotes healing of the wound by increasing circulation to the area, and it moves stuff in and out. The application of negative pressure therapy is indicated for acute and chronic wounds, and therefore to promote the healing of diabetic foot wounds, pressure ulcers, traumatic wounds, dehisced, surgical wounds. Remember dehiscence? It's where they hear a pop when they cough or when they sit up, and they have now opened up that incision to air. Partial thickness burns, flaps, and grafts. It removes excess fluid, promotes tissue growth, and promotes blood flow. This is the end of this chapter. If you got to the end of this, send me an email with your favorite candy bar, and I will bring a bag of that candy bar to you during class. And this is only open to the first 2 people who send me an email.